Hey, everybody, and welcome to the ASAP Pathway podcast. I'm your host, Dr. Stacy Ochoa. Today's episode will be a part 2 of the conversation with the awesome Dr. Mike DeLuke. It worked so great last time in part 1 to do a joint podcast that we're going to do the same thing again today for part 2, where both of us will be asking and answering questions and having conversations that just need to be had. That way, both ASAP Pathway and the Doc podcast audiences can benefit from the content. For those of you who don't know Dr. DeLuke, he is a cutting-edge orthodontist who went from practicing orthodontics to full-time teaching and coaching to help orthodontists and dentists learn unique approaches to orthodontics that enrich their lives and their practices. He founded Doc, DeLuke Orthodontic Coaching, and the Doc podcast. So for more about Dr. DeLuke, please check out part 1, released on October 27th. So to summarize, in part 1, we provided an overview of when and how interceptive orthodontic treatment can be extremely advantageous and transformational. We reviewed the importance of a thorough diagnosis and treatment planning process. We discussed the literature that supports the value of interceptive treatment and disputed some of the articles that oppose it. Also, we dispelled the notion that docs who perform this treatment are just expanding every kid in an attempt to cure OSA. Today in part 2, we'll provide more detailed and specific treatment options and suggestions for pediatric patients who suffer from sleep-related breathing disorders, compare slow maxillary expansion to rapid expansion, discuss expansion of the mandibular arch, and talk about the possibility of using braces and wires instead of traditional methods to expand and develop the arches. We'll also discuss why we believe many orthos are resistant to this approach to interceptive treatment. So with that, I'd like to welcome Dr. Mike DeLuke back to the podcast. Welcome, Mike.
Thank you so much, Stacy. So happy to be back.
I just am really looking forward to this conversation today.
Same here.
I just think it's just such a great organic conversation that just needs to happen. And I hope this lands on a lot of ears, parents' ears, healthcare providers' ears, our colleagues' ears. Can you just take a moment to review why all of this even matters?
Absolutely. When we talk about treating these kids young, we're talking about changing lives. And that can sound kind of cliche, like, oh, we do this to change lives, but we are really changing lives. When you go in and treat these kids and evaluate their airway, evaluate their presenting symptoms when they come in to see you at a young age, prepubertal, anything from 3-4 years old up until 8-9 years old, there are things you can see that we're not learning, we're not being taught in our training programs, and we're not even aware of a lot of times. I think it's really important to stress, and you alluded to this in the intro, I think it's really important to stress that we're not saying that expansion cures pediatric sleep disorder breathing, mouth breathing and snoring. We're not saying that you need to go expand every patient, right? What we're saying is by expanding the arches and making room for the tongue, you're eliminating a major airway obstruction. The tongue is big, and when it's pushed posteriorly, it can often block the oropharynx. And this is most commonly seen in patients who have narrow arches because the tongue doesn't have space intraorally. It's also important to clarify that we are very big, and I know you and I have talked a lot about this, on the need to diagnose and treat the etiology.
Yeah.
You don't just go expanding these patients that aren't narrow, saying, oh, go in on every young kid, pre-adolescent kid, and just start throwing whatever appliance you're going to use in to expand them, and you're going to cure all sleep disordered breathing. No, that's not the case. What you're doing is you need to take the time as a diagnostician to evaluate whether or not these patients have a transverse discrepancy, whether or not they have an airway obstruction. And if they do, and you address the transverse discrepancy at this young age, oftentimes the airway obstruction improves. And this phenomenon has been well documented. We referenced last time the 2022 study in sleep medicine published by our colleague, Dr. Audrey Yoon, and her colleagues at Stanford, where they studied the 60 patients with a mean age of 8 years old and found that the expansion group experienced a statistically significant decrease in both adenoid and tonsil volume compared to the untreated control group. So we know there are data out there that prove that when you help grow them intraorally, that it has an impact on their airway. Again, we're not saying that you no longer need adenoid tonsillectomy, not at all. But what we're saying is something is going on here, and it's incumbent upon us to investigate this further. And to that point, another reason why it's such an important discussion is this affects these kids in more ways than just, oh, well, they've got some crowded teeth. And so often our profession, orthodontists, look at the patient for their teeth instead of looking at the patient for their overall presenting symptoms, for the pattern of pathology that's going on here, right? So we have to be cognizant of those relationships because it does tie into neurocognitive issues, hyperactivity, ADHD. When these patients aren't sleeping, when they're not getting deep, restful sleep, it affects them systemically. And that exists throughout the otolaryngological literature all over. There's multiple articles to demonstrate that. One quick one, in 2006, the International Journal of Pediatric Otorhinolaryngology, they reviewed 33 articles, which included a study population of 22,255 children. So just a couple.
Just a
few. And they concluded that sleep disordered breathing in children is conclusively associated with behavioral, neurocognitive, and quality of life problems. So when we talk about why this is important, that's why. So if we, as the dentist and orthodontist, can look at these patients when they come to us, and oftentimes they're coming or we see them and we might see crowded teeth and narrow arches, look more at them. Look for the allergic shiners. Look for the Denny Morgan lines. Look for the chapped lips, the chapped gums, as I call them, the adherent plaque on the anterior teeth, the apparent reports of restless sleep and or hyperactivity, right? Look into have a cone beam, look at the nasal passageway patency, look at the pharyngeal patency, start to look at the tongue space. That's all we're saying. We're not saying that we diagnose obstructive sleep apnea. We're not saying that we take the role of the physician. We're just saying stay within your lane, but make sure you understand your lane.
Yes. And we have a place at the table. We really do. We are all at this table with our specific roles. And I love that you said stay in your lane. Because, some of these, and I guess too, there's some companies out there that in the dental field that are almost kind of making some really broad blanket statements about curing OSA, really giving us a bad name.
Yes.
And I think,
thank you for mentioning that.
I had a sleep physician actually say to me, and I won't mention the company, but he goes, Stace, what's up with this company, doing cone beams, telling people that, measuring their volume and saying, I'm going to cure your OSA by, you cannot look at a cone beam at the volume. That's a static image of a dynamic, of a dynamic airway. It's like nailing Jello to a wall. It's like, you can't look at that and say, oh, you have OSA.
Exactly.
You can't say, I'm going to cure that either. I mean, if we had a cure for OSA, I think, everyone would know about it by now, but no one has the cure. So what we're doing, like you said earlier, it is removing obstacles. It's multifactorial. It's you do sometimes need tonsils and adenoids, sometimes removed.
Yes.
Sometimes they shrink. After expansion. We know that based off the paper you just referenced.
And about 1,000 cases I've seen it happen in my own practice.
Exactly. So there are a lot of pieces to the puzzle, and dentists and orthodontists and pediatric dentists, we have a seat at the table with our medical colleagues to look at our patients with like a continuity of care and to have more of a collaborative relationship with each other. And maybe they do their thing first. Maybe they punt to us and we do ours first, but it's working together and having conversations and giving parents options and autonomy to decide maybe what treatment they want to start with first, So it is important because these are children that are growing and they've got one chance in that window.
Yes.
And we are becoming the primary care of the airway. They see us often, more than their pediatricians. And it's our obligation and for the ADA to say it really should be the standard of care for screening for dentists, and if you don't want, like you said in the last podcast, if you don't want to actually do the therapy, you don't want to do the interceptive ortho yourself, that's okay.
It's okay.
But it's our responsibility, just like a primary care physician. They may not say, I'm going to handle the sleep, but they're screening for the sleep problems, and then they refer appropriately.
Right. And that's okay. There's no shame in that.
That's okay.
Just don't hate on those who do want to.
Exactly. So I wanted to dive in. So in part 2, we were definitely going to go into more techniques and what is currently existing. What makes your approach? Because when I first met you, I was like, wait, what are you doing? It was interesting. Wait, what? So if you could tell us a little bit more about what you're doing that's a little different than what is being traditionally done for arch development.
Yeah. As I said, that's a common reaction I get, whether it's orthodontist or dentist. And what you said, I just completely echo. And thank you for stating that so clearly. I think it's really important that we get those points out there. And in the podcast I had with Dr. Luke Chimera, who I know you know as well.
Yeah.
A couple months back, he talked about a time when he went to the airway meeting with the ADA, and the guy next to him was an orthodontist and was bragging about how much money he was making because he doesn't have to do anything except they just throw this appliance in every single patient that they get, and it's making him all this money, and he's treating it as airway orthodontics. That is the problem, right? There is the problem. I find that probably more offensive than the ones who are just ignoring this even exists.
Yes.
At least those are kind of willing to, maybe we can teach them, we can help show them. Someone like that, they don't have the patient's best interest in mind and at heart. And that is a major violation for me. This requires more work, more diagnostics, more time, more energy, more resources. But when you do it, you have the ability to transform patients' lives in ways beyond anything just straight teeth actually do. And I'm not minimizing straight teeth. It's just when you have the other podcast I had with the mom and dad that talked, when you listen to those parents explain how their child's life changed through this, it's really hard not to hear that, as all of us care about our patients and go, maybe there is something to this, right? Like maybe. So again, that episode, maybe we can link that one in the show notes, because I think that's one that a lot of people would be very interested in hearing. So back to your question of why, how I'm doing it differently. So I started doing this, it was 20 years ago, came out of my residency, really didn't have any training in the sense, I had amazing training, but not a lot nothing in airway and not a lot in early treatment, right? One of the problems is in our residency programs today, we just don't get access to younger patients. So we're not really seeing or treating. If we see them, we're just kind of screening them, and they're not really, in most residencies, you're not really treating these younger patients. So you kind of come out and you don't really know how to do a lot of interceptive treatment. It's kind of a problem with the educational system. I just got this feeling, as I mentioned in part 1, that I'm looking at these kids and going, I just don't feel like extracting teeth is the real solution here, because that's not the cause, isn't big teeth. So I started using expanders, using upper and lower expanders, and we'll talk more about the literature for that in a moment. The problem is people, parents, kids hate expanders, right? Like I was working on designing one, fitting one with a resident yesterday for reversible headgear. And, they're never fun, right? They're never fun. And so if I really felt like, God, there's got to be a better way to do this, but I didn't think there was. So what happened was, what I was doing, I want to be clear, and I'll go into the literature on this more in a moment, but we're not talking about expanding the mandible, right? We're talking about dental alveolar expansion of the mandibular arch. So I looked at it and I said, well, I'm slowly tipping these teeth out on the bottom to develop the arch. I'm going in on the top and I'm putting this rapid expander in on these younger kids, say 7 years old. Do they need that much force? And so it just kind of started about maybe 5-6 years into my career where I started doing it. It was actually some patients who had special needs and they couldn't tolerate expanders. Mm-hmm. And I told the parents, I said, they begged me not to send their child. I'm like, the only thing we can do is extract teeth. Like we have no choice. They are going to they had significant crowding. And the parents are like, Dr. Mike, that'll require like multiple times going under deep sedation, general anesthesia. Like I don't want that for my child. So I said to them, all right, I'll try something. And I said, I think with some basic, just some mild oral sedative, I think we can get the braces on based on the patient's temperament. And they agreed. And I said, do you think, he or she could tolerate them once they're on? They're like, yeah, they're really particular. They'll definitely take care of it. I said, okay. if we get braces on, we can try to do as much as we can with braces. I don't know that it's going to work. I had in my informed consent, this may not work, right?
Right.
Like we may have to pull teeth, but it's not going to hurt anything. And so I started doing it. I put light forces on, put braces and full braces and wires on these patients in the early mixed dentition, and just started to see what happened. And Stacy, when they started coming back in for their adjustments, I'm looking in the mouth going, calling my like a clinical team over, like, you guys have to come see this. This is nuts. Like, I couldn't believe what was happening. And as a UConn purist, biomechanics, Charlie Burstone guy, I'm like, wait a minute, like this isn't supposed to happen.
This can't be happening.
This isn't happening. So I tried it on a couple other patients. Then I took some patients and I said, well, maybe I'll just do this on the lower, because on the lower, when you're doing slow expansion, it's dental alveolar. I said, I'll just do lower braces and an upper RP. And did that for a little while. And that was working great, working amazingly well. And then I was like, well, let me see if I can push this envelope and just some of these patients not do the RPE. Let's see how we can do. And the reason why we can do that, and we'll talk about the literature, as I said, more in a moment, but it has to do with age and patient age. And so if you put these braces on these patients, and that's how I do it, I put full upper and lower fixed appliances, braces, and wires on these pre-adolescent patients in the early mixed dentition. And what it does is it creates amazing results. A lot of times, expanders, they take narrow V's and they make wide V's, right? So you put an expander in a Hyrax type expander, you get this wide V. Well, where do we often need the space in these patients? Not in the posterior. It's usually in that anterior to middle third of the arch. So you get these beautiful horseshoe-shaped arches. You get tons of room for the canines, the incisors. You develop these arches to have this shape. Well, what does that also do? Makes more room for the tongue. And what I found was when I used a turnkey expander, you would still sometimes have this high vaulted palate.
Yes.
Right. And, it wasn't that beautiful arch shape and form that you want. And the tongue oftentimes couldn't get up in there because the expander is blocking it. What I found is with braces and wires, the tongue does a lot of the work too. And I am convinced of it. So you're using that light force to draw the teeth out, and you're getting orthopedic change too. We'll talk about that more in a moment, but then the tongue can get in there, position itself more superiorly and anteriorly, and start to shape that palate. And when you look at the before and afters of the cases I treat that way, we can put some up if we want,
That'd be great.
We're watching it on video. We can just put a couple as we're talking here that can kind of pop up some before and afters. It looks different than anything I'd ever seen before using turnkey appliances, no matter what type of appliance, or a quad helix, or a W arch, or a nitinol expander, or what, doesn't matter. Nothing I did looked like this and worked like this. And it also minimized the need for a second phase. Didn't eliminate it always, but when I did have to do a second phase on these patients, it was a layup. I mean, it just was so straightforward. So that's the crazy way I do it, that I've now treated thousands of patients that way. I started doing it in like 2011 that way, and have tons of data to substantiate everything that I've been doing.
Which is what I love too, is you're not just saying, hey, this worked. I mean, you do have really great records and before and afters, which I was very impressed with. I wanted to go back to what you said about the tongue, because a lot of this, people will come up and say, okay, what's the appliance? Like, what's the magic appliance? I'm like, look, there isn't a magic appliance.
Right.
And every child's different. But what you said, this is it, really. You said the tongue did most of the work for me. Mm-hmm. Well, let's get back to what natural craniofacial development is all about. The tongue drives the growth, right? Something happened along the way that dropped the tongue. The tongue stopped developing that upper arch.
Why do you think?
The upper arch is...
And why do you think we don't understand? Why do you think we don't recognize that as a profession?
Right. It's like... all we're doing is getting that tongue back up there to do the job it was supposed to do in the first place. Right. And in a child that is nose breathing properly and swallowing properly, because there's a myofunctional component to it as well.
Yep.
They are developing a beautiful arch. Yeah. So getting that tongue up there to do its job, that's the whole point of all of this. Like, we aren't miracle workers. It's really the tongue. And we're just allowing that tongue to get up there. It's basic biology.
Completely. Conversely, we completely don't argue over the fact that a tongue thrust blows everything open.
Exactly. The tongue can do just as much damage as it can do helpful things for us.
So if the tongue can push the entire maxillary mandibular dentition anteriorly and make them bimax protrusive with an anterior open bite, why couldn't it help shape the palatal arch and the palatal vault
in the correct way?
Correct way? And why couldn't it obstruct an airway if it's going backward? I like it. This is where I just kind of sit there sometimes and say, why are we
We're
arguing
missing that.
about this?
It's so funny. It's just, some of it is so obvious. Like when we said in the last podcast, like you explain this to a parent and the light bulb, they just look at you, go, oh yeah, makes total sense. It's very basic, it's very basic. And then you've got people arguing, online, these, orthos and dentists about, I'm like, it's the tongue. Okay. We got to get the tongue where it belongs. When you look at the palate should be almost like a tongue print. It should look just like a tongue.
Yeah.
And when you look at a palate that's V-shaped and narrow, and then you look down at this rounded, beautiful tongue, and they don't match, it's because that house hasn't had the tongue living in it.
And so it's going to go somewhere.
And the tongue's got to go somewhere. So it goes down and back.
Yep.
So we want the tongue. It's interesting too. Somebody said this, I think it was Mike Mew years ago told me this. Every muscle has an origin and an insertion point. Every muscle. Mm-hmm. The tongue's insertion point should be up in the palate, up and forward. Mm-hmm. So when the insertion point of the tongue is not there, then you have this low tongue posture, down and back. The upper arch isn't developing. So to think of the tongue, like where's its insertion point for a lot of children today, it's the floor of the mouth.
Yeah.
Their insertion point is the lower anteriors.
Yeah. Yeah.
And that's not where it belongs.
And this is where the diagnostics, like in a cone beam, are so beneficial because you can take that coronal slice and look at. I just did a coaching session with some docs the other day, and they have cone beam, and I was taking them through it, showing them how they can pick some of this stuff up. And I sliced it and I said, look at the tongue. And you see this invagination, this V-shaped dip so this void between sort of the depth of the V of the dorsum of the tongue and the inferior border of the palate. And there's this black, almost heart-shaped sort of black lucency there. And I'm like, that when you see that, the tongue is not shaping and forming the palate. The tongue is squished in. The tongue shouldn't have this huge, deep invagination in the dorsum. That's not what's supposed to happen, especially on a 7-year-old kid.
Yes. So, you get a lot of information there. And, but did you see, so when you're doing this, I want to go back to how you had your epiphany. So you started seeing these beautiful arches being developed. What did you notice with the palate, though, with the braces and wires technique in these younger kids? Did you see vaulted palate change?
Amazing. We'll put a couple up for those who are watching this on a video platform. It's amazing what I saw, and I've got it in cone beam, so you can look at it in every slice or dimension radiographically plus clinically. And then I have in some of my courses I show some of the cases I used to do when I did it with RPE, the before and the after, and you see a wide arch with a high vaulted palate still, right? And then you take someone who presented almost the exact same presenting palatal shape, crowding, tooth positioning, and you do it with the braces and wires, and you look at their post, and it's like, wait a minute, what? Like, how is that even possible? So yeah, I started seeing it. It's another really interesting point, Stacy, is so my initial wire is an 014 nickel titanium thermal wire, not a very strong wire, right? You're not going to get a significant force that's going to really enact much orthopedic change in that. But I'd see these patients come back 8 weeks later after I put that wire in, and I'm like, they're expanding. Now, some of it, you get a little bit of dental alveolar tipping of those teeth because they're constricted.
Right.
But I'm going, but it's more than that. Like there's no way this wire alone was able to do that. So my theory is the wire starts some dental alveolar tipping of those primary teeth in the buccal segments. And then the tongue now starts to be able to fill into that area and helps you along the way. And by the time you're into like a 1622 or 1725 nickel titanium wire, which can deliver, upwards towards 600 grams of force, which is plenty from the studies that talk about how much force you need to have orthopedic change of the maxilla in a young pre-adolescent patient. And a lot of the studies say it's like 200 to 400 grams ish is what you need, which say 453 grams, give or take, is a pound. So you're talking about, you need like a half a pound to a pound to get orthopedic change in a young patient, not a 14-year-old kid.
Right.
Very important to we're talking about a patient who, yes, there's no interdigitation of the palatal suture. It's completely patent. So when you do that, the studies are very clear, and there are numerous studies out there that document this, that's the amount of force that you can get orthopedic change. I mean, going back to Ricketts in the 70s, he knew this with his W arch and the quad helix concept. So I just took that and said, okay, well, when you deliver that, and as we talked a little bit about before, you're never really, when you design that appliance in a really high vaulted, narrow palate, you're not getting that thing up super high. You're just not.
You can't.
Especially with like a quad helix or something, you're just not. Your line of action of force is not up at the height of the vault of the palate, period. So I said, well, a lot of this is kind of pushing on the sort of toward the crown of the tooth anyway. What if we just go to the buccal and use these wires? And so when you get that amount of force, which is plenty by the literature for orthopedic expansion in young patients, you start shaping the arch. But to your question, it happened faster than I thought. And I'm going, there's something else going on here. And that's where the tongue comes in, because the tongue is so strong. It's able to, once it starts having a home, it starts to go there, which gets to a question I want to ask you. There's this big debate of when you should start this, right? And the tongue is a muscle. There is muscle memory. I saw empirically in my patients, the ones I got at a little younger, 6, 7, the changes were like instant and very quick, because maybe they hadn't developed the perfect mature somatic swallow, but they weren't so far from kind of that infantile swallow, the thrust forward, that they are able to be pliable enough that it just self-corrected. I found those patients that were a little older, 9, 10, where I'd still push that envelope because they still have patency there of the suture. I found that those patients, it was harder. Like the arch didn't develop as quickly. And again, just me theorizing, the tongue is most likely was so much more habitually postured or was functioning in the wrong way or wrong place that it wasn't helping me out. So we've talked about this. You actually start this and have done this younger on patients younger than I have.
Yes.
Talk to me a little bit about that. When are you doing this? What age are you doing this? What are you doing at that age?
So it's so interesting because the tongue is, it's nature's expander. That's really what it is. Nature's expander. So, that was the original expander, and just something went wrong along the way. And so you hear the average expansion 8, 9, 10. What in my group of practitioners, where we've been learning from each other within ASAP and just collaborating with other orthodontists that are very airway centric, they started, which pushed me to start doing it to push the envelope, start expanding younger. I have colleagues expanding 2 and 3-year-olds. So now I have colleagues using fixed bonded expanders in as young as 2 with reverse pull face mask. And it can happen, and they can be compliant. I've done it on, 4 and 5-year-olds. And it's, again, some patients are a lot more accepting of that than others. Yeah. Others are like, this ain't going down. We're not doing this. They're not going to handle it, especially special needs. Or sensory, you've got children with a lot of sensory issues.
Absolutely.
That palate, you block that palate, you put all that stuff in there, you're going to send them off the edge. Completely. They can't do it.
I saw that in 7, 8-year-old patients.
Yes. So there is this.
I should clarify, when I was doing it with expanders, that went
when
away.
You were doing it.
That went away when I went to braces and wires. Sorry.
So then, here's the debate, even among the expander population of practitioners, like, okay, Hyrax is just tooth supported, so you're not really getting the bony changes. So then they started. You really want to grab the bone. You want to do more of a bone tooth supported expander to really change the palate.
Yeah.
Well, then we started. Actually, I want to give props to Audrey Yoon. She started doing some stuff with Invisalign first in 2 and 3-year-olds, doing ClinChecks, saying, look, we don't have the studies yet, but what I'm seeing in my practice, like the symptoms are going away in these kids. They're sleeping better, they're breathing better. And and they're just so soft and pliable and
Mhm.
juicy. Like
Yep.
they move so easily. We don't
Yep.
have to put a lot of force. So going back to that, you know, we are seeing kids younger and younger. When you see the malocclusion, if they're going to tolerate the therapy, it's like, let's try doing some Invisalign, or
Yeah.
it would be interesting, you know, brackets and wires. I don't know how young we could go with that. That'd be interesting, because I know you've gone 6 and 7, but you've talked about, you and I have talked about even, well, here, let me go back to the expander too. The part of the expander that does bother all of us, I mean, it does a great workload, right? But you're blocking the tongue for that period of time.
Completely.
You are blocking the tongue, which is the ideal expander. And you're definitely not encouraging it to go to the home where it belongs. That's for sure. So sometimes you actually see kiddos doing a little worse first. Before they get better.
I saw it often.
They get worse before they get better. And or, you know, sleep physicians are like, hey, let's go ahead, and you've done all this expansion. Let's do a follow-up PSG. Well, let's not do it with the expander in, because their tongue can't go up there. So you're probably going to not see good results if that expander is in. So it would be, you know, ideal to have something that wasn't blocking the palate for that period of time in these soft kiddos. And you and I have talked about the research, or even just like slow maxillary expansion. There's a whole camp of that, you know, rapid versus the slow expansion, even in the palate with palatal expanders. And then, so can you go into a little bit of what you've come across just with some literature with rapid palatal expansion and kiddos under like 10 years old? And
happily. And I actually have an article that by the time this launches, it might have just come out. It's going to be November's edition of
awesome.
Yeah, it's going to basically the I had an article I published in June that started talking about just thinking about this differently, right? Understanding.
Where was it published, Mike? So people can
pause for a second. I'm drawing a complete blank. Why? You know the my God, I want to say Ortho Pearls, but that's the study club.
Was it Orthotown?
Thank you.
Okay.
Okay. So, oh my God, talk about a brain block. I think it's not live.
It's early. It's early.
All right. So I published an initial article in June in Orthotown, and that article went into kind of the background, the etiology, things that we were talking about a lot in part 1 of this podcast and the beginning of today's. The second one, which is coming out in November, is actually going to talk about the different types of expansion. And one thing that, you know, Contemporary Orthodontics, Prophet's book, is kind of like a biblical text in the education of pediatric dentistry and orthodontics, with good reason. It is just a phenomenal text with so much great info. And Prophet is such a renowned figure in our profession. When I saw this, someone had mentioned it to me, and I went back and read it, and I'm like, I never stuck. But Prophet actually said that using rapid maxillary expansion in young children is a quote unquote disadvantage and can cause facial distortion. He also said that there's no evidence of any advantage of rapid movement and high forces in children, and ample evidence that it can be dangerous. Dangerous. So his conclusion was that slow expansion is the preferred approach to maxillary constriction in children in the primary, he actually says, primary and early mixed dentitions. So stop and think about that for a second, right? You know how often I'm guilty. I threw an RPE into a 7-year-old kid and told him to turn it once or twice a day. That's not right.
And describe some of the changes. Like I've seen studies where it said there was vomer drop.
I mean, you have parents that notice this stuff. And I've seen it in our study groups online, are some of the main ortho study groups, where people will post and say they've got a patient who the mom is like outraged, and she's saying that this kid now is having nasal problems and to change the shape of his face and his nose. And obviously, when you do expansion on these young kids, you're changing the shape of the face, but in a very positive way. It's more natural. It's broader. It's symmetrical. You're helping redirect the vertical growth away from vertical. This is like distortion, right? But Prophet said this. He knew. The research has been there that this is excessive force, and you're seeing widening of the ala of the nose, all sorts of other issues. So we had this debate. When I first say this to most of my ortho colleagues, they're like, wait a minute, And in the podcast with Lou Chimera, he said that at first, and then Lou, being such a smart guy, he's like, well, actually, now that you say that, like, I guess braces and wires, if it's delivering the same amount of force as like a quad helix or a W arch or a nitinol expander, because we all know there are plenty of studies out there that show that that works. Bell, in 1982, published something in the AJO at the time. It's now the AJODO. Did a literature review to look at the quantitative and qualitative changes of sutural, skeletal, and dental tissues, right, in humans and animals from maxillary expansion. The conclusion, again, this is 82, this is not new, cutting edge. He concluded that slow maxillary expansion procedures compare favorably with the qualitative orthopedic orthodontic changes reported during rapid maxillary expansion in pre-pubertal age groups. He also concluded that the enhanced maintenance of the tissue integrity, because it's less damaging, and there are tons of studies out there. Melson has tons of histological studies showing that the damage that's occurring on a cellular level with RPE is profound. And when you're 14, there's not much you can do about that. It is kind of like just going to be what's going to happen because you need that much force. Right. Why would we do that unnecessarily to a 7 or 8 year old? But that it's been associated with greater post-treatment stability and less relapse potential. So
yes, I saw an article on that too, Mike, because it was talking about, if you look at the histological aspect of rapid palatal expansion, it's more of a damage reparative
completely
cartilage versus a true bony, like the body likes slow and steady.
It's physiologic.
Slow and steady wins the race, right? So yeah, go back to what you were saying. That article popped in my head too, just about it being reparative damaged tissue. And it's like, oh goodness.
No, that's it. And so that's one big part of it is understanding the difference. And again, I go into that article in this part 2 of my 2-part series in OrthoTown, talking about and giving a lot of the background literature. So for people that want to check that out, we can actually, based on when the release date of the podcast, maybe we can put a link to that in as well. And people can see that because it goes into the literature in much more detail. But the point is there is a significant amount of literature out there. And the data are very clear that when you use light forces on younger kids, you get orthopedic change, period. Right. So people in our profession conflate it and say, light force is just tip teeth. Well, if you're 14, you get some dental alveolar remodeling, but you're not expanding a suture, right? The other big misconception is the mandibular arch. And, as you're pointing the tongue, as we're talking, this is actually something I'm kind of thinking of as we're talking about this. Yeah. Maybe part of the magic of this was, and I know people say magic, they're like, oh, no. I'm not saying this is literally magic. Okay. What I'm saying is it's a wonderful approach that happens in a way that actually blows your mind. Right. So it's the analogy to magic, because you look at it happening in your patient, you're going, whoa, what is going on here? But maybe a big part of that even I've been missing is by me getting on that lower arch, what did it do? Made more tongue space more quickly for the tongue to come forward. And when you just put an RPE in, which is blocking the tongue from even going up into the palatal vault, right? That you're not letting that tongue come forward and be, as I loved you said, nature's expander. So by expanding that mandibular arch, letting the tongue come forward more, synergistically with the maxillary arch, you are actually getting that tongue into a better position. Because I would watch these lower arches just transform in front of my eyes. And I'm like, oh my gosh. Yeah. And people say they get all very uptight, like you can't expand a mandibular arch without surgery. And I have colleagues say that to me all the time. And I say, look, I get the mandibular midline symphysis is fused around birth, right? Clear, but we don't need to debate that. You're not expanding the mandible. You're getting dental alveolar expansion, which is completely physiologic and possible. Actually, 1962, Walter had a study that concluded that the mandibular arch could be expanded permanently. And then in 66, a lot of us have heard of the Schwartz appliance.
Mm-hmm. Yes.
Schwartz and Gratzinger, they presented that in 1966.
Yes. And that is something Sean Carlson, I went to see him speak one time, and he was challenging some of the, I get it. We're not expanding at the symphysis. Okay. We're not saying we're doing, what's the word I'm looking for?
Distraction.
Yes.
Distraction osteogenesis.
Yes, that's the exact word I was looking for. I'm
like, putting some plates down there.
Exactly. We're not talking that, but Schwartz showed that with the Schwartz. You can do a lower Schwartz and they can show that you do get some changes down there, significant. But like you said, we're encouraging the tongue to do its job. Get out of the tongue's way, move the white things out of the tongue's way, let it get up there and do what it needs to do.
And McNamara too. I mean, he's renowned in our literature, and he's done a lot of research on phase 1 over the years. He's reported on the benefits of a Schwartz appliance, and that doing a Schwartz with upper expansion is more beneficial. You get better increases in arch perimeter. I mean, so it's not like this isn't out there.
Right.
That's the part of it that sometimes it's just so perplexing. Neil Kravitz, who is active in the online communities as well. He had an article in the Journal of Clinical Orthodontics, of which he's now the editor, in 2014, which talked about the fact that you want to use an Arnold expander in this case to expand the mandibular arch and increase the intercanine width. And he stated that for maximum efficacy, you need to do this before the permanent canines erupt. So we know this works. We know if you develop that, the whole theory of if you move the baby teeth, the adult teeth don't follow and they just end up crowded anyway is false.
And I never saw that either. People, or even waiting for first molars to erupt, you need to wait for the first molars to erupt because they may not follow. Most of the time they did.
Yep.
But there's ways that you just grab them if they didn't. So, I mean, you make room. We provide a good environment for the tongue to get up and forward, get out of that airway,
correct,
help develop the palate, which is the floor of the nose,
correct,
help do all of these things to remove obstacles. I mean, we have so much impact on these kids, powerful impact. So here's where I'm going to say to you, if we see these articles, I mean, you are throwing out literature after literature after literature supporting that this does work. Why do you think more orthos aren't doing this?
It's such a good question. When I was just giving a lecture to the residents yesterday at NSU, the ortho residents, I talk about that to them a lot. Why in this particular case, yesterday we were talking more about cone beam and why orthos aren't embracing it more when oral surgeons and endodontists and many others, general practitioners, have really understand the value of it. I think a lot of it just comes down to it's hard to change. It's hard to change. When I changed, now looking back, you kind of gloss over it. It's like, oh, it just kind of happened, and I was telling the story earlier, and it's like these patients, I just started doing it. But implementing that in a very busy orthodontic practice that I had is easier said than done. And you have to change your systems, your scheduling. No longer are you, placing separators and bands and impressing or scanning for an appliance and delivering the appliance. All those systems and all those corresponding appointment types go away. Now, once you get through 6 to 12 months of that, it's wonderful because you're not doing that stuff much anymore. But when you go through that transition, and then you've got some patients who are in expanders, and now you're telling other patients you're going to do it a better way, right? And so I had many times where the one patient in expanders, their sibling was the one I'm now telling that we're going to do it a better way.
Wait a second.
But I thought, and there's one cute testimony on my website where the one kid was like, I got version 2.0 because he was so, he's so happy of what he was able to achieve, but his sister didn't, that he didn't have to go through these expanders. So it's hard is what I'm saying. Like it's not, you got to have a lot of scripting. You've got to train your team who you got to tell
huge,
your team,
Mike. Yes, the team is everything.
Yeah. And I mean, they have to understand this. And if you have teams that have worked elsewhere and have experience, they're going to first think like most people think when you say it, like, this is crazy, this can't work. So there's a lot of team education. It's really challenging to implement a lot of this. And even the cone beam, implementing that, you need to maybe upgrade your server. And if you have multiple offices, do you put one in every office? So there's a lot of logistical challenges. Orthodontists, by and large, are very routine. We like our routine. We're kind of ritualistic in that. And it's almost, if it ain't broke, don't fix it. So if you're looking at your cases and you're going, I haven't done it this way, and my patients aren't dying on me, right? Or, because you don't necessarily see what's happening to them down the road, and you don't know if they're necessarily thriving outside your office. But if the teeth look relatively straight after you do, or look good, or you have a good occlusion, or even wonderful after you've completed treatment as an adolescent, it's hard to tell yourself, well, I should be thinking about doing this 180 degrees differently, right?
Well, they're also not asking the questions either. So they don't know that things.
And that's a great point. Yeah.
They're not asking in their screening, about airway questions, or, I shouldn't say they, broad
A lot
stroke.
aren't. Yeah.
A
No,
lot aren't.
Yeah.
And some are. I mean, and some, they will say, I can see your mouth breathing, send them to the ENT, but then they minimize the impact that they have
Yes.
post tonsil and adenoidectomy, right? So
Completely.
they're doing a piece of it, which kudos to them. Okay. They're referring to that ENT.
Agreed.
Great, because not all of them are. So those of you that are, thank you.
Yes.
You're changing that child's life.
Agreed.
You're removing an obstacle. But man, you hold so much power to change that child's life, in addition to the tonsils and adenoids coming out. Like,
and
you
how
really,
many kids have
really
you seen that had the tonsils and adenoids out and still snore or mouth breathe? Maybe not as bad, but they still do.
They still do. And that's, I mean, the ENTs will tell you that.
Yes.
So then you and I have gone into more orthos. Why aren't more orthos doing this? And then now you've got, so then why are so many GPs and pediatric dentists doing it?
Yeah, that's what why do you think, why? Because that's a big thing. The orthos are kind of, a lot of the orthos, and look, I'm agnostic on this. I want what's best for the patient. I don't get involved in the whole, I'm an orthodontist, I went to more school, I am the expert in this. Like, we all are looking at the same patient. We all are dentists. At the end of the day, we want what's best for our patients. It's not like we should be pulling rank here, that we have more training or are better. If we've done something more and are more proficient in it, that's a different discussion, right? But if you're just talking about training and knowledge, I've never been one to be like, oh, only the orthodontists should be the ones that are involved in these types of conversations and discussions. So the orthodontists get very upset when they hear, oh, well, these GPs and pedos are starting to do this. And I've actually said to people very established in my profession, if the orthodontists don't wake up on this, the pedos and GPs are going to start eating our lunch and realizing that we're missing a window to care for our patients. And they're going to start doing it because they understand that we're not doing it the way we should be. So to ask you that question, why? I'd love to hear your feedback on what got you into it, and what you think, in talking to your general practitioner and pediatric colleagues, has them motivated to start to do this.
Well, I was actually talking to an oral surgeon the other day, because we get this even with possibly periodontists and oral surgeons when general practitioners, primary care dentists start placing implants. They have two options. They can get defensive and say, hey, you are doing something that, I'm typically doing, and you used to refer all of it to me. Now you're doing it yourself. And I was talking with the oral surgeon, and he knows that I place implants, and actually the periodontist in town, he goes, look, the more implants you place, I feel the more you're going to refer to me, actually. Yeah. Because you now have a better understanding of what, and it is so true. And the oral surgeon said to me this week, and I just love it. And you can apply this to the ortho general practitioner too. A rising tide raises all ships. Yep. So if we can just start talking, and maybe the orthos ask, like, why don't you ask that primary care dentist, why are you doing it? And we'll gladly tell you, one, we wish you would. And because most orthos aren't, we have to do something, because we do see the demographic, we do see the population, we do see the changes. So we're not going to sit and basically supervise neglect and wait till they're, all their baby teeth are out and someone wants to put brackets on, or some kind of palatal expander later in life. After all the neurocognitive deficits have, been pretty much hardwired in, we're going to act now. And
so I want to dig just 1 second on that. I think it's such a great point, but what I'm hearing you say is, and I want to just make sure I have it clearly, it's not that you're doing this to seek to take the work from the orthodontists. You're doing this because the orthodontists aren't doing it, and you see a need which would benefit the patient. So instead of, at that point, willfully neglecting to help a patient that you could help, no different than leaving decay in their mouth or leaving periodontal disease, you see something that, as a professional, your ethical and moral responsibility is to address. You try to encourage an orthodontic colleague to do it. They want none of it, and probably tell you you're crazy for even asking. And what are you to do as a pediatric dentist and general dentist now? Just be like, well, no, I'm going to throw up my hands. I mean, I can't imagine it's easy for you to integrate another type of treatment concept. I wouldn't want to be in the middle of my day placing an implant. I think what you as general practitioners do, and having multiple family members in that field, it's hard. You have a lot to do.
We have a lot of balls in the air, Mike.
And yeah.
And you're right. And you did summarize it. So like within ASAP Pathway, we do teach screening and diagnostics and collaboration and working with medical and our dental colleagues as well. And we have plenty of dentists that may not necessarily want to do the interception, but they want to build a community and make an impact and help their own children in their house, their neighborhoods, their families, and their practices.
Yep.
And they're looking for orthodontists, right? And so then we do have orthodontists in ASAP Pathway too, but we do have plenty of general practitioners that are doing the interception themselves because they're like, look, nobody's doing it. Mike, I was flying to Philly. I flew my son to see Mariana Evans years ago because nobody would do what I needed done in town. And that's why I am where I am at. I mean, I had to do all the studying, and I'll talk to orthodontists and they're like, wow, you really know a lot about growth and development. Wow, you really know a lot about, I had to learn it because nobody would do it. And I had to help the kids and I had to help my kids. So where do you see this, our profession going from here?
The short answer is I'm optimistic. I really am. I'm really optimistic. When I started this fight, I've taken a lot of backlash, and I don't mind. I mean, that honestly, it does not bother me. I'm kind of built to be a fighter that way. It motivates me. I know what this does for our patients, and I've seen it. And that's why I'm so passionate about getting the message out there. I want to ask you just to elaborate a little more on the ASAP platform in a moment. You gave a little bit there, but just kind of how people can find you and whatnot. But with the Doc platform, that's why I've built this. That's why my content for Doc won't always be about just primarily interceptive treatment and all that it is now. I'm going to be going into a lot, cleft craniofacial and herps and class 2 correction. And I mean, lots of other things. But the reason I'm so focused primarily on that now is that is my core passion, to be able to educate my colleagues, ortho, general, pedo, to say, hey, wait a minute, something is going on in these young kids, and there's a way we can do it. And I'm going to keep fighting for it. The good news is, and why I'm optimistic, even though I've faced a lot of backlash on it, is the people who are taking my courses on my website, the people who are consuming my podcast content and listening to this and seeing this and doing coaching with me and learning it, are literally, it's transforming the way they look at their patient care, their practices. They're having amazing impacts on the lives of their patients already, just doing it. And, I launched Doc a few months ago. So, I think it's just going to be a slow grind for a while, and transitioning to what you're doing with ASAP Pathway, talk a little more about how people could directly benefit from that. Because I think if all of us, which is why you and I wanted to put this collaboration together, the more those of us who see this and get this start to put it out there. And I give you tremendous courage for being willing to put your message out and go out there and speak in front of orthodontists who are automatically, a lot of times, very inappropriately going to look and say, oh, well, if you're not an orthodontist, I'm not going to pay attention to that. Well, no, like you said, you have given yourself and taught yourself knowledge that isn't even being taught in residencies. So most graduating orthodontists have less knowledge about what we're talking about than you do. So you become an expert in this arena, and you having that conversation and having a platform like you have becomes incredibly important. So I'm optimistic. I feel it's going in the right direction. I thank you for the things you're doing and your group is doing. And if you would talk a little bit more about how people can kind of get in touch with you on that.
Well, I'm optimistic too, Mike. I'm optimistic. I mean, finding you makes me more optimistic. So when I come across someone and we just happen to connect, and it's like, I really do think that, again, going back to a rising tide raises all ships, your community, our community, the ASAP Pathway community, it's an online platform. We have a community of mentorship. We have live courses, things like that. We teach pediatric dental sleep medicine as well.
Oh, great.
So understanding that aspect, but it comes down to, I think people need a safe place right now, Mike. I think people need a place where We're all working together. We're collaborating.
Versus just like throwing something on social media and getting a barrage of negativity. And yeah, that's a good point.
So I think, having a group where people feel safe to ask the questions, where an ortho, a GP, a pediatric dentist can go and they know, look, I can ask really vulnerable questions in here. I can challenge thought processes that are currently existing and mindsets that exist. And we all learn together and we raise each other up. And at the end of the day, we are sharing stories of how we're helping kids. And man, we just all encourage each other. And like you said, when you're coaching one of your clients and you're like, you get that success and you see the aha moment for them, there's nothing like it, because the future of our world are these kids.
Yeah.
We could all just close our eyes and, we're all just still little 7-year-olds in big people's bodies, really. I mean, it goes so fast, and our job is to provide a clear path for these kids, walk alongside them, help them get as many obstacles in interfering with their growth and development out of the way for them. Nothing's perfect, right? We're still learning. Gosh, Mike, we'll probably do another podcast and talk about some new literature that came out. We're all learning together.
Completely.
We're
including
in the
physicians
trenches together.
and ENTs, and they're on my cleft craniofacial team. They're picking my brain. I'm picking their brain. That's a great point. This is in its genesis, and all the literature and data. There's tons of evidence base for this going back 100 years, literally, as we talked a little bit about in part 1, but we haven't really coalesced it and put it together. And it's been these little pockets of people or areas that may be doing it and understanding it. And now it's time to say, no. We're going to create one big unified front to say, this works and we're not going away. And we're going to show you this works, because we're fighting for these kids to do what's right for them.
Yes. Amen to that, friend. I'm excited about more conversations together. But before we go, I have, just a walk down memory lane for you, since, kids are important and, childhood is precious. And I just have 3 questions for you. So first, what was your favorite after school show to watch when you were a kid?
Who's the Boss?
Oh my gosh. Who's the Boss?
Yeah.
I love that show.
Yeah, it was always on earlier. Yeah, it was such a great show.
That's a good one. Yeah. What was your favorite cereal when you were little?
Grape Nuts. So bland, so boring.
What?
But so
Grape
boring.
Nuts. Why? Why'd you like Grape Nuts?
I was like always into eating healthy. I didn't like sugary cereals, and I was particular about what I would eat. And for some reason, they were one of the healthier cereals back then. So
You've always been a health nut.
I've got this man of these masseters. I needed to maybe that's why chewing grape nuts.
Thanks to Grape Nuts for those masseters.
When I was 8 to 12 years old. That's why I've got these masseters. Yeah.
Oh, good for you. That's the healthiest cereal I've heard so far. So congrats on that. Okay. And who was your favorite superhero when you were a kid?
When I was a kid, Superman. Yeah.
Oh,
yeah.
That was mine too.
Yeah.
I loved Superman
for Halloween one year, and Superman without a doubt. Superman and a close second would be the Hulk. So that was. I guess I'm trying to live vicariously through that, but the Hulk. That was another big one. But those are my 2 favorites.
I love it.
I thought of it because I was also literally green. I painted myself green one Halloween as a kid. So
I love it. And Mike, you're a lot of kids superheroes. You're a lot of kids Supermans, and I appreciate Superman, and I appreciate what you're doing in the community. And let's keep working together to raise that tide, so all of us do better for these kids.
Yeah, thank you so much. I can't thank you enough for this, and let's entertain doing more. And just as time goes on, we're going to be in touch. And I think the more we can just get this content out there, and I just give you so much credit for what you're doing and putting all this together. And it's been fun for me to collaborate with you, and that's how the message gets out there. So.
Wonderful. I love it. Thanks, Mike. Thanks for having these conversations and being so brave. And I look forward to more conversations.
Same here. Thanks so much.
Thanks, Mike.
All right.
Bye.
Take care. Bye.